and we're able to bring another one of our clinician interviews to you today. One of my good friends, I've known you for a long time, Dr. Tarun Agarwal from Charlotte, North Carolina. Tarun, how are you doing today?
Oh, fantastic, Michael. How are you doing?
I'm doing good, and you are actually out here lecturing with Sirona, talking about the integration of their cone beam X-ray unit with the Chairside system. Is that correct?
Yeah, it's a little bit more. We're talking about the cone beam and how it works with CEREC at the same time. But absolutely, we're here to share. I'm here to share my clinical story about how we're using the technology and how it's made a difference for our practice.
And so in terms of how that's integrated, we'll get to that a little bit later, but I want to ask you about something else. I've seen an interesting trend in dentistry where a lot of people, starting with the first time I heard it was from Dr. Gordon Christensen, telling dentists, it was probably 15 years ago, saying, if you take out wisdom teeth, you have the surgical skills to place an implant yourself. And despite him saying that over the last 15 years, I placed my first implant probably 3 or 4 years ago, and I did guided surgery because I was nervous about doing it, and with the guide I found it to be very easy. Tell me a little bit about when you got started, and if you remember, tell me a little bit about your first implant experience.
Yeah, it's a great question and a great story. I think what happens is we're afraid to admit that we're fearful. And we should be fearful. There's a nerve down there, there's a sinus, the different things that we can make mistakes with. But I look at it from a perspective of, listen, I was the guy in dental school who passed out watching a tooth being taken out.
Really?
So I don't really have
And you weren't even the one taking it out?
No, I was, in fact, I wasn't even the one assisting. I was the one standing in the background and just kind of seeing the forceps wiggle and a little bit of blood bubbles coming out, and right on the floor.
Really? So
yeah.
You and literally passed out. But you had done
literally.
endo and crown and bridge before, and were okay with that?
No. I was just watching them. This is my first year of dental school.
Oh, got it. Okay.
I was just watching them take a tooth out.
Got it. Okay.
And I just, boom, out, cold. It was awesome, actually. It's a pretty funny story to share with my dental school classmates occasionally.
I bet. I'm surprised they didn't. I didn't know what the protocol would be. So they probably take you somewhere, the ammonia inhalants, and then kick you out of school, or they let you stay?
They did raise my tuition after that. It's amazing.
Yeah,
they said, for someone like you, I think we may need to charge a little bit more.
And so you got over that. Do you remember extracting your first tooth?
It's interesting. I was so afraid to take out teeth. I was one of these dentists that I'm a crown and bridge restorative guy. That's all I do. I do crowns, I do bridges, I do fillings, and that's the extent of my situation. And then I reached a point of frustration. We had patients that came in, and I'm not a big believer in bridges. I wasn't 10 years ago, 15 years ago. I'm certainly not today. And we'd have these patients. I'm like, listen, you really need to do an implant here. And they'd go, and I'd send 20 away, 30 away, 40 away. And I would notice that 15, 20% of them came back with the implants. And I would ask the patients why. I said, well, I don't feel like going over there. Why can't you do it for me? Or sometimes they'd come back and they'd be in a little bit of a wrong spot, made my whole case not go well. And I got fed up with it, to be honest with you. And I said, you know what, this can't be that hard. It really can't be. So I took some implant training. I look at technology, and it really started coming together when we looked at technology. The technology really made it much simpler for us. In fact, I remember my first case that we did. I brought my implant rep in because, when you first start, you're not willing to buy any of this stuff. You want to try it. Right. They bring it all in. You just really need somebody that'll hold your hand. It's really what it is.
Exactly.
I'm surprised I didn't just have him do it for me.
He probably could have if you would have passed out again in the middle of it.
Yeah, if I had passed out, he could have just done it for me.
Finish it.
So I numbed the patient up, and we did it. And literally, I remember going, we're done? He goes, yes, we're done. I go, God, that is amazing. It's almost like stealing. My patient goes, uh-huh.
And this wasn't guided? This was freehand?
This was guided.
Oh, it was guided. Okay.
Basically, I did, in my programs, I go over my whole story. It's quite funny. My first implant I ever did, you schedule the whole afternoon for it because you're just scared out of your mind.
What year was
this? This would have been 2005.
Okay.
2005. I would have done my first implant, and you schedule the whole afternoon for it. You take X-ray after X-ray just to make sure. You put a round burr on and take an X-ray to make sure you didn't screw that up.
Right.
And then you don't have to worry about irrigation because the sweat from your forehead
exactly.
just irrigating
lubing
the site,
it up.
Lubing it up.
Right.
And it's salty anyway,
right.
so it just tastes just like saline. And I remember it was so scary. And it just didn't go so well. And then I tried again, and it got to a point where it wasn't me that wasn't willing to try; it was my team. and my team stopped believing in me. And then when patients look at your team members and they say, hey, should I get this done? Or they have that look, and your team members don't believe, it stops.
Right, like when you tell a patient you should really have an implant and your assistant's behind you going like this. Don't let him do it.
Telepathic, women communicate telepathic. She's like, do not let this guy mess with you. This one may go in upside down. You never know what's going to happen.
My first one was with a surgical guide as well, and it was just surprising to me the fact that you couldn't get the drill off axis, and it was a depth controlled guide, so I couldn't go too deep. And by the time we were done, I was like, man, that was easier than a bridge prep. That was easier than a crown prep on a second molar. It was easier than a lot of things.
Easier than a buccal pit.
If we had some sort of surgical guide to do a crown prep, where we could set it on the tooth and stick a burr in and go, that's one of my great dreams, is to find something like that.
We don't have that?
There's nothing like that. And ironically, something that dentists think is really difficult, like implant surgery, there is a guide for that.
It's amazing. And I've watched your first surgery because you guys did the DVD on it. And, it's amazing. The hardest part of that is getting all the stuff back there. Right. It's not even doing the drilling and placing the implant. All of that, all of that difficulty is taken away, and the confidence that you're not going to hit the nerve, the confidence to know that if you plan it properly, that the implant's going to be in the right spot, you can be able to restore it easier. It makes, I restore my implants in 15 minutes.
Right.
It's unbelievable.
Did you tell your first implant patient that they were your first
implant?
I can see you doing that. I can see most dentists not doing that. But I already knew, I think, the answer to that question.
What it really happens is the patients ask me, so how many have you done? I go, hundreds. And I just don't, I fail to tell them that they were on typodonts.
Right. Or I used to count dental school at the beginning of my career. I'd count all those patients.
On those ivorine blocks, you did the little amalgam
preps. How many preps have you done and things like that. So they knew it was your first one.
Yeah, they do. And listen, I'm a big believer in being honest and upfront with your patients, and it's amazing when you're honest and upfront with them how they're like honored that you're using them. That patient still comes in and says, "Oh man, look, I started all of this." In their mind, it wasn't without them that I was able to do some of the things that we're doing.
So how long did it take, start to finish, that very first one?
8 minutes. It's on YouTube somewhere.
Is it really?
8 minutes, uncut. Yeah.
You recorded it as well.
Yeah, absolutely.
Wow.
Yeah.
We did that, like you said. And it's kind of a gutsy thing to do, but also, by the same token, there's probably no better way to reach a dentist sitting out there going, you know what, I don't know if I want to try this. This sounds scary. Because you're right, you got a sinus and a nerve, and to show your very first one and let other people see it, that's fantastic. We need to resurrect that on YouTube.
We should. And what's amazing with it is I look back and I'm embarrassed by it because I would do so many things different today. But that one worked.
Right.
95% of these things worked.
Right.
It's amazing.
And so how long was it between when you placed your first implant and then you placed your second implant? Do you remember?
A couple of weeks. 3 weeks, maybe. And now it's a weekly procedure for us. We're doing north of 120 implants a year in our practice, which I think is a small number. I think the potential's phenomenal. It's unbelievable what we could do. And we don't have a large practice by any means. Right. Listen, what I tell people is just count. Think about it. How many missing teeth do you see a day in your practice? If you had 1% of your patients say yes to missing teeth, you couldn't do all the implants.
Right. And as you do more and gain the clinical confidence that you have now, there's just a different aura about you when you talk to a patient about it, and they start saying yes more as well, provided they can afford it. But it's in the beginning, when you're telling somebody for certainly the first time, you don't have that same degree of confidence. Like the first time you're doing a 10 veneer case, it's really hard to say it with a lot of confidence that this is going to turn out fantastic.
Well, I think. I should, right?
Yeah.
But that doesn't really give confidence to the patient, does it?
It doesn't.
And now it's now the beauty of it is now I don't even have to say anything. My team just says, "Oh, listen, we do lots of these. You'll be fine." And that's the trust that you build with this stuff. It's pretty amazing. But really, the way I look at it, Mike, is the case acceptance is part of it comes from certainly your confidence. I think the confidence is the most important thing. But the other part of it comes from the technology. I ask dentists all the time, how many of you guys are impressed? How many of you guys and gals are impressed by the technology you're seeing? And they all raise their hand and said, we're trained dentists. What do you think our patients think when we see some of this technology? It's amazing. You show a patient, I tell my patient, this is your nerve. I need to avoid this. If I hit this, call your lawyer. You will win. And it just puts them at ease, and they know that you're looking out for them. And it's pretty amazing.
Yeah, patients are impressed by curing lights.
Yeah,
let alone some of the stuff that we're able
my
to do
engineer
now.
patient's like, oh, what wavelength is that? I'm like, I have no idea. I'm like, I should know that.
501. It doesn't
know.
really. You should know, but it doesn't really matter because you know where the on-off switch is
I know
on
it's
the
10
trigger.
seconds. I'm not trying to figure out how can I make this 3 seconds.
Exactly. So, what's your favorite part then of placing and restoring implants? Is there a part of it that really, what do you like most about it?
All of it, to be honest with you. I love the challenge in talking to patients and helping them understand what the best choices are for them. I love the digital aspect of it, Mike. I mean, what we're doing in our practice is pretty unique. I'm a relatively humble guy, but it's pretty unique. You can walk into my office and in 2 visits I can have you finished. I mean, planned, placed, surgically guided in place, and then restored in the 2nd visit. Mm-hmm. And it's pretty amazing. And what we've seen is it's tremendously affected our efficiency, made us more efficient, allowed us to make things more affordable, but yet have clinical excellence without having to drive prices out of that. Right. And look, I know a lot of us don't like to talk about money and the prices, but some of our stuff is getting a little out of control for patients. Average patient can't afford this stuff, and our goal shouldn't be is how much can we charge. Certainly we should try to make profit. Don't get me, I'm a businessman. I want to make profit, but we need to think about the patient and what can we do to keep costs reasonable.
Right. And I'm guessing, I think I already know the answer to this, but are you the one are you willing to talk money to your patients when you talk about this stuff and they ask how much is it all going to be?
Yeah, it's a good question. It's a great philosophical point. The answer is yes, I'm willing to talk about the costs, but that's where I end it. I don't get into the details about insurance because I don't even know what insurance the patient has.
Right.
I don't get into the details about how to pay for it. We have a trained professional in our office. Melinda handles that. And I just tell the patient, listen, Melinda will sit down with you. You guys will work it out. Whatever you guys decide is okay with me. But I let them know. And on that point, I think one of the mistakes, the big mistakes I see practices making when it comes to implants is they can never tell the patient a fee. I mean, if I ask you, Mike, what is an implant going to cost? You'd be like, first question is, does it need a bone graft? Right. Does it need a custom abutment? Does it need a stock abutment? All these questions. And all patients hear is like, Jesus Christ. It's like going to a mechanic. And so one of the things that we did, where we saw our business start skyrocketing in implant terms, is we went to a flat fee. For example, in our office, a posterior tooth is $3,500 from start to finish, whatever it takes. If that needs a minor bone graft, it needs a minor bone graft. If it needs a tooth taken out, it needs a tooth taken out. It's all part of the fee. That way I can look at the patient and say, Mrs. Jones, this situation is going to cost you $3,500 from start to finish. Melinda will sit down with you, go over the insurance details, figure out a comfortable way for you to take care of it, and then we'll go from there.
So there's probably going to be times where the $3,500 was a little bit higher than it would have been had you quoted separately. Then there's going to be times where it's a little bit lower than had you quoted separately. And it's kind of like, if a crown is $1,200, there's going to be upper second molars that are darn near impossible to do.
Hard.
And then there's going to be a bicuspid that's got endo, and it's going to be simple to do.
You don't even have to numb them up.
Yeah, or you just cut off an old crown and boom, pack cord, everything's ready to go. The porcelainage is fractured off. So I think the idea of a flat fee is smart, and maybe most dentists would say, well, that sounds weird to do it that way, but we do everything else in dentistry that way. There's no sliding scale.
Listen, for me, it's about it's how I want to be treated when I go somewhere. I would just want to. Bottom line, what's it going to cost me? Don't give me some. It might be this, it might be that, but it's easy for my team members. So when a patient asks my team member, hey, you're missing that tooth, and then the team member can't answer the question, right. What's it going to cost? My team member can confidently say, in our office, it's $3,500 from start to finish. We don't believe in a nickel and diming our patients. Right. And how I came up with that number, and I'm not suggesting 3,500 is the number, because in Southern California you can barely eat for $3,500. Okay. What I do is I say, take your low end fee. Your implant, stock abutment, crown, take your high-end fee, implant, custom abutment, crown, bone graft, and come up with a fee somewhere in the middle. Listen, at that point, a few $100 doesn't matter to the patient. No patient's going to say, oh, I can do it for $100 less. If they trust and believe in you, it's a non-issue.
So how much are your anteriors then?
My anteriors are $4,000, $4,000. And the reason is those I always put a provisional in the anterior. I spend a little more time contouring the tissue and getting them right. So our fee should be more. And patients are pickier about their front tooth than they are about their back teeth.
Absolutely, they are. So that makes sense. But you know you're going to have to spend extra time, and there's a chance you may have to send the crown back to the lab and get them back again, especially if it's a single tooth. It's the toughest thing to do in dentistry.
It's not a chance. A single tooth, it's almost guaranteed.
Right.
You're going to have to send it back if you're picky.
Right.
You know, if you're particular, if you actually care.
Right. That's why like 70, 80-year-old men,
yeah.
they just don't care, and they can't see.
My favorite is the Vita Shade Guide patient. You know, the patient that said Crown of the Year Club, they've had a PFM done on all their teeth, and it's A1 one year, A2 another year, C1 the next year. You just pick one, right?
It's just easier to make them all A2.
It doesn't
from
matter
start
anymore.
to finish. We should just, as dentists, agree that the only shade we're going to use is A2.
Whoever invented the shade guide's terrible. It should just be one color.
I know. Well, you've seen my all A2 shade guide before, haven't you?
Yeah, I have.
Where I take all the other shades out and I put A2 in there, and we cover it up with little sterilization
patients look
tape.
like I want that one. Like they can tell
the
difference.
patients say, I'll be honest, doc, they all look the same to me, and I go, yes, the untrained eye. I remember before I could see all the subtleties between it, but it's this one, and I pull it up. We should start selling the all A2 shade guide. So what % of implants are you placing yourself, and what % are you having your specialist place?
That's a trick question. Okay,
yeah, I know.
I think you're like my wife. My wife must have called you this morning. Let me start by saying this. We control 100% of our cases in the office, okay? And I probably place about 70% of the implants that come through our office. And what I mean by that is none of my patients come in asking for implants. They're asking for a solution. If you're missing your front tooth, you're not going to come in and say, hey, I need an implant. Right. I mean, how many patients walking around with 6 implants and they had no teeth on them? Right. You know, they're asking for teeth. So at the end of the day, I'm responsible for the final outcome. So I control 100% of my cases. And when I say control, I collaborate with my surgeon when necessary, when it's beyond my skill level, when it's beyond my medical history, comfort and all of those things. But about 70% of the patients we're able to treat ourselves. But it wasn't always that way. You know, we started with single teeth, simple back teeth, and then progressively I call it my implant journey, where some of the stuff we're doing is amazing.
Well, what I learned on that first one, I had it cherry picked for me, and the second and third one were the same way. And then as I started saying, well, I want to do more of these, I realized that placing the implant itself is the easy part, especially with the surgical guide. It's replacing the missing bone. And so really, as much as I think a dentist who hasn't placed an implant worries about that, it seems as though a really helpful skill is learning to bone graft well. And was that part of your journey as well?
Yeah, it has been. In the beginning, just like you, I cherry picked, and that's I only picked cases that didn't need grafting. And what I found was over time that was my limiting factor. Right. Okay, now I have patients that have, and it works great when your patients, like me. I mean, I got this much bone, this much height, it's no big deal, right? But over time, you run into patients that just don't have enough bone. And that was the next part of my journey is how do I get bone there? Or a patient that's missing an upper molar and the sinuses come down a little bit. How do we bump the sinus up a little bit? And that was the next part of our journey was being able to add the grafting material. And I was scared out of my mind, or socket preservation. When you take a tooth out, preserve that bone. Make sure that there's enough bone there. And it's I don't want to say it's easy. I don't want to say it's simple. It's not nearly as difficult as you think.
It becomes routine.
Yeah.
I mean, it's not that it's necessarily simple, but it becomes routine like molar endo might be. And it sounds like you're treating it the same way that most GPs treat endo, for example. They'll do the easy ones in their office, the general ones, and then the specialist gets referred the special cases, the super difficult endos. And that's
specialist, right?
And that's essentially what you're doing with implants, it sounds like.
It's funny you say that. That's an analogy I use. When I talk, I ask the audience, I always say, how many of you guys do molar endo? And it amazes me how many, all the hands don't go up, okay? But the ones that do, I say, how many of you guys do every molar endo that walks in your door? And none of them say yes. I mean, there'll be an occasional endodontist in there, right? Like you have no choice, right? But I say, well, how do you look at it? We look at an X-ray and you know if it has a hook, that's not for me, right? If it's calcified, it's not for me. And that's what the cone beam technology has done for us. You can be in my chair and I can look at you and I can say, Michael, you don't want me to do this implant. Let me get you to someone who can. And how would that make you feel if I told you that? This guy's so honest. Yeah,
the honesty and not to, you're turning away the opportunity to take some money from me for doing that service, and you're honest enough to say, you know what? This is beyond my... And the older you get in dentistry, the nicer it is to not try to be the hero all the time.
It's
and
amazing.
Not want to have to do that stuff.
I can't wait the day comes I don't have to do a buckle pit anymore.
Right.
I always say this because I hate buckle pits. I'm like, how are these things on my schedule? I mean, I know they need to be done, but literally, how are they on my schedule?
Exactly.
Like, why? Why couldn't we do that in the hygiene chair when they were here, for God's sakes?
And I've had patients come in over the years, and they have veneers on already that I think look pretty decent. But they have a 3-page list of all the things they don't like about it. And that's why I've always wished there was a cosmetic specialist. because I can't charge enough to justify the stomach lining and sleep I'm going to lose if I try to replace these.
And
but there
they're
aren't
picky.
any. So, but fortunately, David Hornbrook's about 40 minutes down the road.
Well, you're lucky. Let him deal with those, right?
Yes, he's got the patience and he charges enough and the skill and the expertise to be able to pull that off. So
And
you're
that's the
doing
key.
70% of them, you'd say.
Yeah, 70%. And my ego says I can do 110% of them, okay?
Right.
But the reality of it is not every case is right for me. Right. But I'm there for the patient to get the tooth. So I collaborate very closely with my surgeon, and I believe in a team approach. And the team approach is the restorative specialist, general dentist in my case, the surgical specialist, sometimes that's me, sometimes that's my oral surgeon, periodontist, and the laboratory. And now sometimes I'm the laboratory as a CEREC owner, or sometimes I work with my laboratory. And it takes all three of these moving parts to make a case work, from the simplest case to the most complex case. And I think sometimes what happens, we lose sight of all the things that it takes to make these cases happen. And we don't collaborate. We don't pick up the phone and call the lab and say, hey, what do you think? What do I need to do? How much clearance do you need? Does this implant need to be here? How many implants do I need to put in this spot? Where do I need them positioned? And that's the difference between where I was 5 years ago and where I'm at today, is that ability to recognize in advance what's going on.
Right. Well, that was fantastic. Thanks so
Mike.
much for
Appreciate
dropping
it.
by.
Yeah,
Appreciate you
absolutely.
sharing your knowledge, experience, and actually being so forthcoming about your fees. Fees are, nobody ever wants to talk about them, but it's really good because that idea of the flat fee, I think, is going to make it a lot easier. You've seen what we've tried to do at the lab. We try to do flat
Everything's
fees for implants
That's where
too.
I got
because,
the idea from.
Yeah, because it's such a crazy thing, and dentists hate that kind of uncertainty. Dentistry is hard enough, especially if you're losing money on it. So thank you for being so honest and sharing all that stuff
It was a
with
pleasure.
us. On behalf of myself, Tarun, and everybody here at the lab, I want to thank you for your time and your commitment to quality dentistry. That's why I like 70, 80-year-old men. They just don't care, and they can't see.